Right after World War II, the United States launched an aggressive public health campaign to control infectious disease. Military leaders worried that sexually transmitted infections threatened troop readiness. Between 1946 and 1948, in Guatemala City and at multiple other sites, including penitentiaries, military barracks, and the National Psychiatric Hospital, a program led by Dr. John C. Cutler of the U.S. Public Health Service, deliberately exposed vulnerable people to syphilis and gonorrhea to study transmission and treatment. The project was framed by institutional priorities. Surgeon General Thomas Parran, Jr. had made venereal disease control a wartime and post-war priority. Military reports from 1945 and 1946 documented STI rates among servicemen, and penicillin's wartime emergence made experimental treatment protocols urgent. Guatemala, governed by President Juan José Arevalo after the 1944 revolution, was politically fragile and subject to heavy U.S. influence. Diplomatic pressure, promises of medical aid, and unequal power dynamics opened access to prisons, barracks, and hospitals where oversight was minimal. Ethical protections were weak. The Nuremberg Code would be articulated in 1947, but internal review mechanisms in the United States and Guatemala were inconsistent or absent, and project files and classified memoranda kept the operation shrouded in secrecy. Investigators used invasive methods: inoculation with infectious material, scarification, and arranged sexual exposure in some locations, to produce intentional, controlled infections so they could watch disease progression and test therapies. Subjects were often prisoners, soldiers, sex workers, and mental patients who were coerced, uninformed, or paid nominally. The program affected more than 1,300 Guatemalans and left corrosive, ghastly consequences. Scientific ambition, imperial leverage, and bureaucratic secrecy combined to create procedural and moral conditions that enabled systematic abuse, setting a dark stage for the revelations and reckonings that followed. In late 1946, physicians from the U.S. Public Health Service presented a brutal experiment as urgent science. Their goal was framed in clinical terms: figure out how syphilis and gonorrhea spread, and whether penicillin could prevent infection when applied after deliberate exposure. The project was driven from Washington by the Venereal Disease Division under Surgeon General Thomas Parran, Jr., and field operations were led by Dr. John C. Cutler, a U.S. Public Health Service physician who traveled to Guatemala City to run the protocol between 1946 and 1948. The stated aims sounded technical and clinical: map transmission, measure incubation, and test prophylactic dosing. But the methods were grotesque. Investigators targeted populations they could control: inmates in Guatemala's penitentiaries, conscripted soldiers, women working in brothels, and patients confined in the National Psychiatric Hospital in Guatemala City. Recruitment was transactional and coercive. Men and women with little freedom of movement were offered small payments, promises of treatment, or were enrolled through prison and military authorities who granted access in exchange for U.S. assistance. The protocols normalized cruelty. Technicians collected pus and infectious exudate from known syphilitic and gonorrheal lesions and applied that material directly to abraded skin. They used urethral and genital inoculation to ensure infection. In some locations, technicians arranged supervised sexual contacts between infected sex workers and selected subjects to produce controlled transmission. Medical records and project memoranda, later examined by historian Susan Reverby in 2010, show explicit plans to create active, festering infections so investigators could observe untreated disease and then test timing and dosing of therapies. Decision-making was compartmentalized and cloaked. Subscribe. Apparently, ethics didn't get the memo. Local Guatemalan officials, U.S. PHS supervisors, and field clinicians kept information separate so that no comprehensive ethical review ever occurred. Memos routed through the Office of the Surgeon General and field reports treated people as experimental material rather than patients. Early moral compromises were rationalized as public health necessity in the name of protecting U.S. troops and global populations. As procedures became routine, Clinical staff grew desensitized to painful chancres and oozing lesions. By the time the program had enrolled more than 1,000 Guatemalans, the infrastructure of secrecy, military and prison cooperation, and clinical normalization had created a self-sustaining machine of experimentation. Those conditions made the program's ghastly outcomes inevitable and set the stage for the exposure, accountability, and public outrage that followed. Recovered decades later, project files, clinical notes, and internal protocols exposed the program's scale in unforgiving detail. Between 1946 and 1948, field reports and laboratory logs record more than 1,300 Guatemalans enrolled across Guatemala city penitentiaries, the military barracks at Villanueva, and the National Psychiatric Hospital, with explicit instructions to produce active disease. Clinical charts list repeated inoculations, scarification of skin with purulent exudate from syphilitic chancres, urethral and vaginal installation of gonorrheal material, and scheduled supervised sexual exposures. Many subjects were exposed multiple times to guarantee infection. Pathology logs describe the resulting wounds in clinical grisly terms: purulent, ulcerating sores, chancre formation, necrotic tissue, and draining lesions that clinicians logged as active lesions or failed prophylaxis. Consent is effectively absent from those files. There are no robust informed consent forms, only terse notes that men and women were enrolled after promises of treatment or small payments, and a memorandum that describes prisoners as available material. Survivor accounts collected later and cited in historian Susan Reverby's 2010 research recount deception, coercion, and betrayal. People told they would receive routine exams or care were instead stripped, scarified, inoculated, and monitored as their bodies broke open. Repeat exposures were routine. Clinical schedules show many subjects exposed more than once, sometimes after receiving partial or placebo doses of penicillin, so clinicians could observe incubation periods and therapeutic timing. Officials rationalized the work with bureaucratic euphemism and strategic framing. Memoranda from the Venereal Disease Division and statements attributed to Surgeon General Thomas Parran Jr. and field staff stressed the urgency of protecting U.S. troops and advancing penicillin science. That language minimized individual suffering and reframed mutilation as necessary data. Oversight failures were both structural and deliberate. The project was compartmentalized across U.S. Public Health Service channels and Guatemalan institutions. Internal reviews were informal or omitted, and the newly articulated Nuremberg Code, 1947, never translated into restraining policy on the ground. Laboratory technicians and physicians grew desensitized, recording pus, fever curves, and serologic titers with clinical detachment, while patients endured corrosive infections and social stigma. The human toll runs through those sterile data sheets. Men and women with ulcerating genital lesions, psychiatric patients driven to deeper trauma, and soldiers forced into degrading exposure protocols. The arithmetic of numbers cannot conceal the moral calculus that sanctions systematic harm. These files and testimonies harden into evidence, pushing the story toward exposure, public reckoning, and the difficult questions about accountability that must be answered next. For decades, the evidence was filed away and minimized. That changed in 2010 when historian Susan M. Reverby, researching U.S. public health history, uncovered archival records that clearly mapped the 1946 to 1948 Guatemala experiments. The documents included memos, clinic logs, laboratory sheets, and correspondence that named John C. Cutler and the U.S. Public Health Service Venereal Disease Division, and that laid out inoculation protocols, prisoner lists, and supervision tied to the Office of the Surgeon General. When Reverby shared those records with journalists, international outlets broke the story in October 2010. Images of clinical notes describing scarification, urethral installations, and active lesions moved quickly from bureaucratic files into front-page news and broadcast reports, turning archive entries into a public moral crisis. The reaction was immediate and painful. Survivors and family members came forward with testimony about ulcerating chancres, draining wounds, and the social stigma that followed. Guatemalan authorities, led by President Alvaro Colom's administration, demanded full investigations and accountability for what had been done on Guatemalan soil. U.S. officials faced diplomatic fury. Secretary of State Hillary Rodham Clinton publicly apologized on behalf of the United States, calling the experiments shocking and abhorrent, and U.S. health agencies ordered internal reviews and searches of institutional records to establish who knew what and when. Congressional leaders pressed for hearings, Guatemalan prosecutors opened criminal inquiries, and human rights groups called for reparations and prosecutions. Some veteran public health figures and commentators urged context. Penicillin's novelty, post-war anxieties about troop readiness, and looser consent norms of the era. Critics, bioethicists, and survivors rejected that contextualizing as a cover for inexcusable brutality. The clash was stark and public. Government statements and legal filings met anguished testimonies from men, women, and families who said they had been lied to, coerced, or treated like living laboratories. Clinical detachment in the archives collided with memories marked by scars and shame. Investigators combed files for chains of command. Memoranda that once read as bureaucratic euphemism were scrutinized for language that minimized enrollment or described prisoners as available material. As diplomatic channels sputtered between apology and defensiveness, the inquiries raised technical questions about culpability and jurisdiction, and more searing moral questions about how a nation's medical apparatus could engineer such deliberate, festering harm. That mounting demand for answers pushed the story toward a climactic confrontation between institutional silence and victims who refused to be reduced to sterile data. When historian Susan M. Reverby revealed the 1946 to 1948 Guatemala files in October 2010, a long-standing silence broke, and a ghastly public reckoning began. Photographs of clinic logs, scarification protocols, urethral installations, and notes cataloging pus-dripping chancres turned bureaucratic secrecy into visceral evidence. Survivors described necrotic, ulcerating wounds, draining lesions, and lifelong stigma. Guatemala's President Alvaro Colom demanded criminal investigations, and Guatemalan prosecutors opened inquiries. On October 1, 2010, Secretary of State Hillary Rodham Clinton issued a formal U.S. apology, called the experiments shocking and abhorrent, and promised cooperation. U.S. health agencies, including the Department of Health and Human Services and the Centers for Disease Control and Prevention, ordered internal reviews and searches of institutional archives. Congressional leaders demanded hearings to trace chains of command linked to John C. Cutler, the Venereal Disease Division, and figures associated with Surgeon General Thomas Perrin, Jr. Independent investigative panels and interagency teams were convened to reconstruct protocols, interview clinicians, and compile forensic timelines. The revelation forced a broader interrogation of institutional responsibility. Committees probed whether the ethical breaches were prosecutable crimes or civil wrongs, while bioethicists and survivors pressed for reparations and formal accountability. But the moment also exposed structural limits. Key files were incomplete, misfiled, or missing. Witness accounts were vivid, but documentary proof was fragmentary. Legal barriers such as sovereign immunity, statutes of limitation, and jurisdictional hurdles constrained prosecutions. Apologies, investigations, and public hearings revealed a corrosive moral failure, but produced only partial remedies. Compensation efforts stalled, criminal accountability proved elusive, and many victims were left with raw scars and no full justice. It became a bitter test of whether institutions would truly atone or merely document the horror. The 2010 exposure of the 1946 to 1948 Guatemala experiments forced a practical and moral audit of how human subjects are protected, and it left a corrosive mark on public trust in medicine. The scandal renewed attention to the basic principles first articulated in the Nuremberg Code, 1947, and to regulatory frameworks developed later, including the U.S. National Research Act, 1974, which created Institutional Review Boards, or IRBs. U.S. agencies like HHS and the CDC launched internal reviews. Congress demanded inquiries, and bioethicists turned a harsher spotlight on informed consent, especially for prisoners, psychiatric patients, and other vulnerable groups. Practically, the episode hardened expectations. Clear, documented consent, independent and cross-border ethical review, transparent protocols and funding, and explicit protections against coercion in international trials. Comparisons to the Tuskegee syphilis study revived discussions of racialized medical abuse and systemic impunity. Many legacies remain unsettled. Survivors and families still seek legal redress and reparations. Official apologies have offered only limited closure, and public skepticism persists where wounds were opened. Contemporary global health partnerships must learn from these failures, build genuine local oversight, equalize power, ensure reparative justice, and treat consent as non-negotiable. The question that remains is blunt and urgent. Can medicine repair the deep wound trust it helped create?